Hello, and welcome to this webinar from the Immune-Mediated Inflammatory Diseases Forum. We have this webinar we're hosting it on personalized medicine, and we have here collaboration across specialties and on rheumatology, dermatology, and gastroenterology. It is my pleasure to be running this webinar with my colleagues together with me today. My name is Sofia Ramiro. I'm a rheumatologist and senior researcher from Leiden University Medical Center, the Netherlands. And together with me, we have Professor Herve Bachelez, Professor of Clinical Dermatology from France, and Professor Tim Orchard, who is from the UK, from the Imperial College Healthcare. Trying to pass the slides. Yes, so starting with some housekeeping. So please, I would like to ask you to stay muted during this webinar, but that should not make you shy from asking questions. So please, and I would like to encourage you to ask any type of questions through this webinar. You can use the Q&A button for questions that you can have, where I will be looking at them and we will be addressing them to each of the speakers at the end of the presentations. And if you have any questions or are experiencing technical issues, please use the chat box for that. So we will start with some presentations on the different areas addressed in this webinar. We will address advances in personalized medicine, starting with rheumatology by myself, continuing in dermatology by Professor Bachelez, and gastroenterology by Professor Orchard. And then at the end, we will have a Q&A discussion before we close this webinar. So feel free to ask your questions, please. And without further delay, let's get started with the area of rheumatology, and in that case, by myself. These are my disclosures. And personalized medicine is an area where we have a lot of interest, and actually where we all would want to see large improvements. We all would want to avoid the one-size-fits-all approach to our patients, and we would like to see that through personalized medicine, we are able to identify subgroups of patients, either because a different mechanism of the disease or a different treatment response or different prognosis, patients that we know we can treat differently. And if we use the example of rheumatoid arthritis, in the last years, decades, understanding more its pathophysiology has seen a big progress, and this has led to the development of innovative treatment options and strategies, which has led to improvement of treatment outcomes. However, we would like to have better basis for our treatment options to avoid the one-size-fits-all approach in our patients. And biomarkers can help us here. If we think about how we approach treatment, if we look into this figure on the left-hand side, we have actually our current situation. If we have a patient with undifferentiated arthritis or rheumatoid arthritis, we start usually with the same type of treatment. Then we assess whether the patient is responding or not. And with a series of trial and error, then we see whether the patient responds to one treatment. If not, we go to another option. Ideally, we would like to have the scenario of the right-hand side with a personalized medicine where identifying specific characteristics of patients, we would tailor the treatment to that patient. Imagine, for example, a patient with undifferentiated arthritis would get a specific treatment, a seronegative RA, another different treatment, and a seropositive RA, another different treatment. And then based on the positive response or not to treatment, and on sets of biomarkers, we could predict which would be the next most suitable treatment option for that patient. This is an ideal world and not necessarily what we are yet doing. There are different biomarkers in rheumatology, fortunately, and we make use of them every day in our daily clinical practice. At least, I would say, rheumatoid factor and anti-CCP, we widely use them, especially in diagnosis of patients with RA, also in identifying the prognosis of these patients. And we know that high titers of anti-CCP have been associated with the better response to certain biologics, although we also know that that evidence can be, to a certain extent, thin evidence because there's evidence contradicting it, but we will come back to that. And we also know that it has been shown, for example, high titers of anti-CCP have been shown to be associated with higher risk of progression of structural damage, so progression of erosive joint disease. Then we have ESR and CRP, which are inflammatory markers we use in daily clinical practice and that are associated with worse outcomes. So higher inflammation associated with more structural damage, more functional impairment in patients with RA. So it's used in daily clinical practice as a marker to suppress inflammation. Then the multi-biomarker disease activity, the MBDA, has been identified, has been a biomarker that has been identified with levels or associated with levels of inflammation, and therefore also as a predictor of structural radiographic progression. However, I think the challenge here already becomes as to what extent does it really perform better or in addition to other factors we already know that are associated with, in this case, more structural damage progression. So the challenge is when identifying new biomarkers, not so much at what they are associated with, but what they are providing in addition to what we are already doing in daily clinical practice. And this brings me to some limitations. As I was already hinting at biomarkers, we usually do not have, or we usually have problems either with specificity or sensitivity of biomarkers, or both. We all know that rheumatoid factor lacks specificity, and we see it positive in many other conditions that trigger antigenic stimulations. Anti-CCP lacks sensitivity and fails to identify a large proportion of patients with a seronegative RA. And then ESR and CRP are aspecific inflammatory markers that can be positive in many other conditions. So there's a lack of a consistent biomarker measurement standards, and their non-specific specificity mainly also results in multiple limitations. In terms of biomarkers that have been used or have been identified at the level of investigation, there are plenty of them. Here is a list, not very extensive, but I would say the biomarkers that have throughout the last years have been most identified in different studies, so consistently identified. So we have biomarkers like anti-MCV, serum 14-33 ETA, anti-CARP. So these are biomarkers that have been associated either with the presence of the disease or worse outcomes. But again, comes the challenge of whether they provide a differentiation in the setting of what we already measure. So for example, antibodies to anti-CARP have been found in patients with the serum of patients with RA, but studies have not showed any increased sensitivity or specificity when compared with the rheumatoid factor or the anti-CCP that we are already using in daily clinical practice. So ideally, we would want better biomarkers that can help us with an earlier diagnosis, treatment, and outcomes, but it is a challenge to identify them. So we see a lot of literature on biomarkers, but making the next step into daily clinical practice, meaning having added value compared to what we are already doing, that's the next level that is more challenging, of course. There are several biomarkers that I think are worth some more words in the field of rheumatoid arthritis, because they have led to important studies, important trials. If we look at synovial biopsies, there have been a set of RCTs with a very good reasoning for them, a very sound hypothesis, in which synovial biopsy has determined the treatment or the stratification of patients according to which a treatment is defined. For example, in this R4RA trial, so in patients with RA who have an inadequate treatment with TNF inhibitors, patients where a synovial biopsy was collected, and then the hypothesis would be that in the population that is poor to B cells, so that rituximab, so anti-CD20, would perform or be less efficacious compared to an alternative. Here, the alternative used was tocilizumab. So synovial biopsies were conducted and patients were stratified into the poor B-cell poor population, B-cell rich population, and then randomized into rituximab and tocilizumab. And there were no differences between these arms. That is not the data we are seeing in here in these tables, because afterwards, or in parallel to the synovial biopsies and to the histopathology of those biopsies, they also conducted RNA sequencing classification. And according to that RNA sequencing and stratifying the population into B-cell poor and B-cell rich, then the patients were randomized to rituximab and to tocilizumab. And in the B-cell poor population, so on the left-hand side, there seems to be an indication that tocilizumab treatment was superior to rituximab. On the right-hand side, on the B-cell rich population, there was no difference in terms of clinical outcomes. Here, clinical outcomes were a CDAI of at least 50% improvement, or a major treatment response, which was the second row endpoint that combined a CDAI of at least 50% improvement with the CDAI up that had to be lower than 10.1. This was, although an open label trial, so there could be problems with the lack of blinding of this study, as tocilizumab has a quicker mode of action, so that could have led to some perception of a better response. So that is a possibility. On the other hand, this trial has also emphasized the challenges that there are with the synovial biopsies and the histological evaluation of them. But nevertheless, there was an indication that tocilizumab seemed to be better or more efficacious in patients who have B-cell poor population, in patients with a B-cell poor population. This led to 2 more trials, and those are now trials that were conducted in patients biologic naive as opposed to the previous trials. And in these trials, also synovial biopsies were conducted, and here were in the B-cell poor population, rituximab was compared to tocilizumab and etanercept being both taken together. So that was the primary endpoint, comparing both treatment options together with rituximab. And here you see the primary endpoint was ACR20, and there was no difference between the treatment arms. In ACR50, there was a slight superiority of tocilizumab and etanercept, but there is no consistent response, because in other outcomes we do not see a difference either. So in B-cell poor patients, ACR20 was not significantly different between etanercept plus or tocilizumab, so both treatment options grouped compared to rituximab. And in the B-cell rich population, there was also no consistent difference in this in the clinical outcomes, but this was not expected. But again, these trials, having a very sound methodology and a very sound hypothesis, have not been positive trials, and they have emphasized the challenges that there are with the synovial biopsies. There are lack of standardized protocols that leads to challenges validating the findings. And that the biopsies were analyzed in one single center with high expertise in this. So imagine if this was conducted across several centers. However, there was a discrepancy between the synovial biopsy and what the RNA analysis identified. So there still seems to be here a potential signal to grouping patients according to their pathophysiology. Then moving to blood biomarkers, these are the ones more extensively used, and I will only mention one, the serum calprotectin, and we will have a lecture by a gastroenterologist who are using much more calprotectin. But if we look here in different rheumatic diseases, we see that calprotectin is actually increased in most of the inflammatory diseases in RA, actually SPA, PSA, compared to healthy controls. but there has not been a clear distinction of seroprotectin being possible to use in addition to what we already used in terms of CRP and ESR. So there seems to be a potential possible relationship there. I mentioned before rheumatoid factor and anti-CCP as factors of determining the seropositivity of our patients with RA, and they are known as prognostic factors of our patients. And there has been some data on some trials showing potential higher efficacy of some drugs, namely rituximab and abatacept, in patients who are seropositive. However, the evidence is quite thin on that. It was not consistent across several outcomes. So within our group, we ought to conduct a post-hoc meta-analysis using data from individual trials. So post-hoc analysis from several trials. Here we have 23 RCTs that were used, and additional analyses were conducted because these data are not included in the main publications. And we have grouped trials according to patients who are CSD-MARD naive, so 6 trials, CSD-MARD insufficient responders, 14 trials, and TNFi insufficient responders, 3 trials. And we can see in general that there was no difference between the response in seropositive versus seronegative patients. Only in the TNFi insufficient responders, there was an ACR 20 that was favoring efficacy in seropositive patients. However, this significant difference was not consistent across other outcomes. So based on the mode of action, efficacy was comparable in patients who are RF positive and RF negative, and also for the different types of drugs. So the effect of biological DMARDs is comparable in patients with and who are seropositive and seronegative, regardless of the population or the mechanism of action of the individual drug, was the conclusion of this meta-analysis. And a last word on imaging. Imaging as a biomarker would be another world as such, but just to mention that, of course, imaging is a biomarker that is frequently investigated. We also use in our daily clinical practice, and there are promising data coming on the dynamic contrast enhanced MRI. Ultrasound is often also used, and this probably, I would say, has already made it to our daily clinical practice in detecting subclinical synovitis, and PET is also explored, although I think there we have to be also more careful about its widespread use. It's not really daily clinical practice, but there's potential for several imaging modalities in identifying who are the patients who have a higher likelihood of having a progressive disease. So in conclusion, I would like to say that personalized medicine has come to stay, and that's something we really want to implement and to bring to our daily clinical practice. I didn't touch upon that, but machine learning and AI are expected to be key players in this and to contribute to this. A lot of research is conducted in this area, but I have to also say that at the same time, while research is advancing, unfortunately, no new biomarkers have yet emerged for everyday clinical practice beyond the traditional markers like rheumatoid factor, anti-CCP, ESR, and CRP. And I think this was a short update that I would wanted to make on behalf of the rheumatology. And now we will see whether the reality is the same or maybe a little bit more shiny in other areas of our other specialties from which we will learn in this webinar. So I think now, without further delay, I would like to introduce my colleague. So Professor Herve Bachelez is a professor at the Department of Dermatology of the Saint-Louis University Hospital in Paris, France. And since 2004, he has been a professor of clinical dermatology at the Université Paris Diderot, Université de Paris. So Herve, please, the floor is yours.
Thank you, Dr. Ramiro. Thank you, Sofia, and for this beautiful introduction as well on rheumatology. You will see in the next minute or so that this topic is by many aspects very similar in dermatology. And for the sake of time, I chose to focus on the very few prototypic examples of inflammatory and immune-mediated skin disease, in the psoriatic disease spectrum. So these are my disclosures. So when we look at the most prevalent immune-mediated and inflammatory skin disease, in most of the cases, we are sort of dominated or driven by two statements. One is that, or dogmas. One is that each clinico-pathologic entity corresponds to more or less a canonical inflammatory pattern, and which results from a deregulation of one or few inflammatory or immunological pathway belonging to the adaptive and or the innate immune system. So let's say you would have IL-23, IL-17 axis dominated psoriasis inflammation. You would have the type 2 immunity dominating the atopic dermatitis pathogenesis. You would have the type 1 interferons, but also the gamma interferon producing T1 cells dominating the inflammation leading to vitiligo, and the type 1 interferons and some T cells driving cutaneous lupus, to name a few. So this is two statements. So one is that all the individuals sharing the same, more or less the same clinical pathological presentation their disease would result to the same pattern. And I will try to show you that this is completely obsolete, and there is no surprise that there would be some patterns in each of the clinical pathological entities resulting to very different mechanistic scenarios. And I took the psoriasis spectrum prototypic example because this is the most advanced, assumingly, regarding the knowledge about the pathogenesis of the disease. And to make a long story short, over the last 30 to 40 years, from in vivo, in situ, and animal models, but mainly from human studies, and also the genetic studies I will allude to, the current view is that at the population level, with plaque psoriasis, which is by far the most frequent disease, which, as you know, is associated in 20% of the cases roughly with psoriatic arthritis. These patients, they have a chronic inflammation, which is mainly driven, like I said, by a deregulation of the IL-23 type 17 axis, meaning that regarding the innate pathway, there are some triggers belonging to the innate immune system, like type 1 interferons produced by plasmacytoid dendritic cells. But again, the big push is given by the IL-23, which is a maturating hormone, if you wish, so cytokine, which is favoring the differentiation of naive T cells into type 17, IL-17A producing cells. And therefore, we move to different strategies that, assumingly, would focus on the dominant cytokines, moving from more TNF alpha blockade to now IL-17 or IL-23p19 after IL-12-23 step strategy. So I will try to comment very briefly on the limits of this one target fits all paradigm. And trying to show that searching for a sort of common mechanisms that would really drive the inflammation in all patients is really flawed. So first of all, these results from real-life studies under targeted treatment, different kinds of biologics, TNF-alpha blockers, IL-17 blockers, IL-23p19 blockers, or 12-23, provided some interesting results. especially because we move from immunogenic molecules, biologics like infliximab, to less immunogenic. Adalimumab might be immunogenic, but lately already ustekinumab is poorly immunogenic, and guselkumab and risankumab belonging to the IL-23p19 inhibitors are very poorly immunogenic, if immunogenic in real life with a clinical significance, I mean. And even though this is the reality, meaning moving to poorly immunogenic molecules, you can see in this the bad beer registry from UK from patients with psoriasis over 2 years period from the initiation of one drug. You can see that the retention of each molecule, what you call the drug survival, can be considered as quite good as a surrogate marker for efficacy, because most of the patients are switching because of primary or secondary loss of efficacy. And you can see that roughly 20% of the patients under ustekinumab are switch after 2 years. And although this is better for guselkumab, which is the last approved, there is still an attrition of the drug survival after 2 years as a proxy of secondary or primary loss of efficacy. And of course, this raised the hypothesis that in some cases, despite even with initial efficacy, there might be some plasticity in the immune system, and that all psoriasis would not be the same functionally or mechanistically. Of course, this is not a demonstration. The second sort of warning came from the genetic models of the frequent disease, and also from the examples of the rare subtypes of psoriasis. So we are dominated, like in rheumatology, but also gastroenterology, this is no exception, by the fact that for highly prevalent diseases such as psoriasis, but also for atopic dermatitis, for vitiligo, these diseases would result from a trouble in the interaction between the genetic background and environmental triggers, and that, again, this would result for a polygenic, multigenic, complex background, and that the single gene model would be the exception and not the rule. Forgetting that for some frequent disease like cystic fibrosis, but also COVID-19 infection, and also tuberculosis, which are very frequent disease, not in the inflammatory disease spectrum. These diseases, they have a genetic background based on a single gene model, which applies to a significant proportion of the individuals, if not the whole population. But let's focus on the polygenic model example. So the genome-wide association studies, from these studies, following the whole genome knowledge, led to the identification of genetic susceptibility loci in all inflammatory and immune-mediated disease. And for psoriasis, HLA-CW6 or CW0602 was a haplotype which was associated with a 5-fold increase favoring the onset of plaque psoriasis, without any molecular model and without any functional model. And the attempts to tackle the significance of having or not this favoring allele, HLA-CW60602 in this case, and this is an Italian study, interesting, with the response to predict the response to ustekinumab, so Stellara. And you can see that when it's the 70% improvement at week 40, but also it's even more, let's say, significant / non-significance, the difference between those who are positive for CW6, this is the red curve, versus the blue curve for the negative. You can see that the difference is very tiny, meaning that you have still a lot of a high proportion of patients who are CW6 negative. They are responding to ustekinumab for a majority of those. And this shows the striking limitations of what emerged from the genome-wide association studies, which is a proxy for the limitations of the GWAS analysis, even though it allows the identification of some genetic susceptibility outside. The situation is, of course, very different when you have the chance to identify the single gene culprit in a single gene model. And this is supposed to be the exception, not the rule. We at the lab and others believe that this is more frequent than in what is expected. And one example of that is the CARD14 dependent gain of function mutations, which has been identified by Anne Bocock's laboratory in the US at that time. And she identified in some Mendelian forms of psoriasis plus or minus psoriatic arthritis, gain of function mutation of this keratinocyte expressed gene, and which, by the way, is responsible for the disease across several disease entities belonging to the psoriasis spectrum. Pustular psoriasis, but also plaque psoriasis, and a disease that we call pityriasis rubripilaris, and also, again, pustular psoriasis. And to make a long story short, human models, but also mouse models, help to understand why the patients with CARD14 mutation that we know for sure is responsible of the pathogenesis of the disease are responding very well to an IL-23, IL-17 blockade, while not responding to the TNF-alpha blockers, is because there is an articulation between the gain of function mutation and an amplified IL-17, IL-23 response. And this was beautifully shown by two laboratories in two different papers in immunity and also GID and science immunology, showing that the knock-in of the mutations observed in humans replicated the disease more or less in the mouse setting. And what is not shown on this slide is that there are some emerging papers in humans showing in some retrospective studies that these patients, again, are responding with CARD14 disease, are responding to the IL-23, IL-17 blockade and not to the TNF-alpha blockade. Of course, you can say IL-23, IL-17 is the canonical deregulated pathway anyway, so you tackle the one which is dominant. So this is not a demonstration. Fair enough. So we move to another example, which is a subtype of psoriasis, which is pustular psoriasis, dominated by the neutrophilic afflux, and which leads to these pustular lesions, which are typical of either localized pustular psoriasis, palmoplantar, and also generalized pustular psoriasis. In this setting, there have been some successful attempts to identify the single gene abnormality, and starting with the loss of function mutation of a negative regulator of the IL-36 pathway, which belongs to the IL-1 family, and our lab was involved in the pioneering description of those in the context of generalized pustular psoriasis with some localized lesions in between the flares. What is interesting in this setting is that this led to the development and the design of drugs inhibiting the IL-36 pathway. So the picture should be very simple. On the one hand, you would have the plaque psoriasis dominated by deregulation of the IL-17, IL-23 pathway. So all the patients should be put on the IL-23, IL-17 blockers. And on the other hand, all patients with pustular psoriasis should be put on IL-36 receptor inhibitor. That's the oversimplifying view. Of course, this is not true. Here is the current picture of the patients with generalized pustular psoriasis. This is from our lab, and you can see that only a minority of the patients are mutated for the IL-36 RN mutation, roughly 20%, and here 21.7%. But some patients are mutated for CARD14, and in our observation, this is unpublished, the patients with the CARD14 mutations are responding to IL-23, IL-17 blockade, and no surprise that the IL-36 RN mutated patients are responding to the IL-36 receptor inhibiting drug. At the population level, the recent approval of the anti-IL-36 receptor in the context of generalized pustular psoriasis, and this is a drug developed by Boehringer Ingelheim, the spesolimab. This is the first randomized controlled trial in generalized pustular psoriasis, showed that not all the patients respond after 1 week to the drug. And although it works across several genetic backgrounds, in the flare prevention studies, the patients with the IL-36 RN mutation tend to respond, all of them, to the upper dosing of spesolimab, which is no surprise, leading to the emerging of one real taxonomy, new taxonomy of rare orphan variant of recurrent disease. So in the pustular spectrum, you would have some CARD14 disease more underlined by the IL-17, IL-23 deregulation. In the deficiency of IL-1 receptor antagonist, which leads to pustular lesions mimicking the pustular psoriasis spectrum, you would have IL-1 inhibitor, which is the way to go. And for the therapeutic approach of the deficiency in IL-36 receptor antagonists, the IL-36 inhibitors, we believe that this is the one way to identify the patients and to be as close as possible to the deep mechanisms which is associated with each population of patients. And last but not the very least, I will end up with the insights from transcriptome studies. The reason is that you can't always identify the single gene abnormality, even in the rare orphan variants of recurrent disease. So in this context, a lot of laboratories identify some markers like by microarrays or RNA-seq, showing that yes, in psoriasis vulgaris, there is an upregulation of markers reflecting the deregulation of the IL-23 pathway, while in neutrophilic disease, you have virtually, this is not central. But if you take MX1 as a reflector of the deregulation of the type 1 interferon pathway, you can see that both in generalized pustular psoriasis and to a lesser extent in psoriasis vulgaris, you have some patients, very few, but they exist, who shows a clear deregulation of the upregulation of the type 1 interferon pathway, for which we know that this is pathogenic. And this is reflected in a series of patients. Basically, from the skin transcriptomic, you can see that the type 1 interferon pathway is reflected here, and you can see that the interferon-stimulated gene, most of these patients are refractory to the currently available biologics. Well, basically, they don't show so much type 17 or IL-23-driven inflammation, but no surprise that they show a striking upregulation of the interferon-stimulated gene, raising the hypothesis that some patients with true plaque psoriasis are really underlined by deregulation, not the IL-23, IL-17 pathway, but by mainly a type 1 interferon deregulation. So we believe that this, the collaboration of AI scientists with bioinformaticians and clinicians, translational scientists, integrating the clinical and multi-omics and with AI, will probably deliver some new disease stratification, but also precipitating reclassification, which is more based on the molecular models, and raising the hypothesis that some patients with psoriasis are more driven by type 1 interferon and are closer to cutaneous lupus erythematosus than the classical psoriasis vulgaris, if you wish. So in summary, precision medicine appears to be a clinically relevant concept and strategy in skin inflammatory disease. Some genetic biomarkers in rare autoinflammatory disease seem predictive of clinical responses, but they can't be applied to all of the patients. And insights from single gene models combined with functional genomics and multi-omics approaches are likely to impact the current inflammatory disease taxonomy and their targeted approaches. And we believe that this integration is really the way to go. And we'd like to thank all the people involved in this work. Thank you.
Thank you very much, Herve, for this brilliant overview. And I think this gives us enough food for thought and questions and topic for questions. But before going to the questions to you, we will move to the next speaker. And I would like to remind our participants to please submit your questions through the Q&A box at the bottom. We will be addressing them soon. And now, without further delay, I would like to introduce our next speaker, Professor Tim Orchard, who is a professor of gastroenterology and chief executive of Imperial College Healthcare NHS Trust in the UK, a trust consisting of 5 hospitals, including 3 major teaching hospitals. Tim, the floor is yours.
Thank you very much, Sofia. Let's see if I can there we are, perfect. So as always, the gastroenterologists are lagging slightly behind the rheumatologists and the dermatologists. But I guess very, very many of the same themes around personalised medicine. In IBD management, I guess there are a few things which are absolutely key moments in patients' pathways. So when to start advanced treatment, which drug to choose, when to switch therapy, and how long to continue treatment remain issues for us. And as both my predecessors have said, trying to avoid a one-size-fits-all is really quite important. And with inflammatory bowel disease, Crohn's disease, and ulcerative colitis, there is a very wide level of clinical variability. And so one of the things that we try to do, I think, is to try and work out which factors can help define prognosis and response to treatment. And I think we've got some helpful advice, helpful information from a range of approaches that have allowed us to phenotype the disease. I think we're probably less good at the moment, as I'll demonstrate, in terms of really working out how to use these data to help drive our decision making. So we know that there are a range of clinical factors that can be associated with inflammatory bowel disease, and the disease is very different. So, for example, if you have isolated proctitis, that is very different from having extensive severe ulcerative colitis, and the prognosis is different and the treatments are different. Similarly, wide range of huge amount of work has been done in the genetics of inflammatory bowel disease over the last 25 to 30 years. And we've identified a load of interesting genetic associations. CARD15 in Crohn's disease, very definitely associated with isolated small bowel disease, but not helpful necessarily in helping us work out what the right treatment is. Similarly, HLA DRB10103 associated with extensive and severe disease in ulcerative colitis, but again, not necessarily helpful in helping us at the moment in working out what is the right treatment choice. Similarly, a load of immunological associations, ASCA and ANCA. ASCA associated with Crohn's disease, ANCA associated with colonic disease, and isolated Crohn's disease. And there are some algorithms which use those, which I will show you in a little while. And then, of course, a multitude now of omics technologies, metabolomics, important in inflammatory bowel disease, microbiomics, proteomics, transcriptomics. Because what we'd like to get to is a situation where you can make a clinical assessment of the disease. You have a panel of either biomarkers, which could be genetic, microbial, immunologic, pharmacologic, to help you decide what is the right drug given a patient's prognosis, and then you start the treatment, hopefully effectively, but if they lose response, then you go back round the loop again to try and work out what to do. And of course, the disease course is very, very important in trying to work out what to do. We know that in ulcerative colitis, there are 4 major types of disease course. Interestingly, the commonest is the one where you have a very severe flare initially, and then you have less severe relapses. But there's a large proportion, you can see 37%, that do have chronic intermittent symptoms. But because ulcerative colitis is a mucosal disease, it tends to be less cumulative. Whereas Crohn's disease is a slightly different issue, and in some respects, I think has this accumulation of damage with time in Crohn's disease is much more perhaps akin to some of the rheumatological conditions. And here, this is a very famous chart from Pariente et al., which Fraser Cummings from Southampton has adapted to demonstrate both the impact in terms of what's happening from an inflammatory perspective, the increase in damage to your bowel over time, but also how that then plays into your life events. And as you can see, you can have episodic episodes of inflammation which settle down and then bubble back up, but the bowel damage is cumulative over time. So you may get to a point where you start to get strictures, then fistulae and abscesses, and then you need to have surgery, and then you have further strictures. And so your bowel function becomes problematic. And the impact on the patient is less to do with the inflammation and more to do with the cumulative damage over time. And one interesting thing that you can see if you look at how we use advanced therapies, and again, we're gastroenterologists, so we still regard infliximab as an advanced therapy, perhaps less so than perhaps we used to. But if you look across a range of trials here at when in the disease course you start the drug, you can see that you have the biggest impact on disease in terms of remission at a year in studies that use anti-TNFs early on in the disease course. So treatment early maximizes the effectiveness of therapy. And of course, that means that it's quite difficult to compare clinical trials because it does depend slightly on at what point in the disease course patients have been recruited. And so it is really important to understand the site, the severity and the stage of disease in any clinical trial, and also whether patients with complications are allowed in. And the trial design is incredibly important. And of course, what that means is that, and in some respect it's good for gastroenterologists, I guess, is that because there's an element of judgment here and personalization, because individual clinicians and individual patients are having to make decisions based on clinical trials that may not directly be relevant to the clinical situation. We're very excited in gastroenterology over the last few years because basically until a few years ago, we only had, well, basically for a long time, we had infliximab and adalimumab. We then were very lucky when we had vedolizumab, the anti-integrin, which prevented white cell migration to the gut. We've now had an explosion of drugs, and it is becoming much more like rheumatology. So we have had ustekinumab, the IL-12, IL-23 inhibitors, but also now risankizumab and other IL-23 inhibitors, the JAK inhibitors, the first generation tofacitinib, but now upadacitinib has a huge impact on our ability to treat these diseases. But of course, given the choice, we now have to try and find a more rational way of choosing the right drug than simply trial and error, as Sofia described so nicely in her first slides. And I think the factors that affect the decision-making, unfortunately, don't reflect any sort of massive level of scientific sophistication. There are disease factors, which I'll come on to, patient factors, and sadly, in a lot of situations, healthcare factors, which are about reimbursement, which help decide what we can prescribe. And in fact, if you go back to what things do we have, clinical risk factors are probably as good as anything. And this is an old paper now, it's getting on for 20 years old, from Laurent Bourgerie, which looked at what are the risk factors for disabling disease course in a population of just under 1,200 patients. And the bottom line is, if you have the disease under the age of 40, if you have extensive disease in small bowel and colon, if you have perianal disease at diagnosis. And if you need steroids the very first time you present, those are all things that are associated with a disabling disease course. But if you combine them, then as you can see, if you have one factor, it increases your risk of a disabling disease course from 61% in terms of positive predictive value to 67. But if you've got 2 or 3 factors, that jumps to a positive predictive value of over 90. So they are additive in terms of predicting a disabling disease course. Of course, it's important to remember that of those 1,200 odd people, actually over 900 of them did have a disabling disease course. So you could argue that what you're really doing is identifying the smaller proportion of patients who don't have a disabling disease course. We can combine those clinical factors with other factors such as the serological inputs, ASCA and ANCA and OMP-C, and also with some genetic inputs. And Corey Siegel has done really good work on this. It's now been commercialized through Prometheus, which allows you to make decisions related to the combination of clinical and serological and genetic inputs, and allows clinicians to sit down with patients to show them what the impact of treatment may be on developing clinical complications over time. And I think that's probably the most effective way that we currently have of using clinical and genetic and immunological factors together. And I wanted to finish by talking about perhaps our most recent foray into looking at personalised medicine in inflammatory bowel disease, because it has quite an interesting set of lessons for us, I think. And that's the work that's based on James Lee's work from Cambridge, that had looked at the phenotyping of particular CD8 positive T cells. And by doing transcriptional profiling, they were able in a smallish population to identify 2 populations of patients, one of whom were able to survive without treatment escalation, and the other of whom needed to have quite significant treatment escalations. And it was better in this study that was published in JCI than ASCA and other clinical judgments. And so Cambridge and Miles Parks did a really great trial, just published this year, called Profile. And this was a clinical trial of infliximab and immune suppression against accelerated step-up therapy. And it was stratified by a 17-gene blood-based biomarker that could categorize people into those 2 groups, determined IBD high and IBD low. And they were looking primarily at sustained surgery-free and steroid-free remission at week 48. There were 172 people in the step-up group that completed 48 weeks, and 181 in the top-down groups, the people that started with immune suppression and infliximab at the outset. And the way that it worked was you were admitted to the trial. If you were on the accelerated step-up, you started steroid induction for active Crohn's disease. They then tapered the steroid, and your treatment depended on what happened. So if you had a flare, you started steroids and immunomodulator. If you had a second flare, you started infliximab. In the top-down group, you started initial steroid induction and then straight on to infliximab and an immunomodulator. The results are very interesting because there was a very clear difference between the top-down and the step-up. So at a year, steroid and surgery-free remission was much, much higher in the step up, sorry, in the top-down group. So treating early was clearly a really important thing to do. And that went for both clinical and also endoscopic remission. If you then stratify that by the two biomarker groups, this shows you here the top-down treatment and their chances of surviving without a first flare. And this is the step-up treatment. So you can see much, much better in the top-down. But if you look at IBD high and IBD low, it made absolutely no difference. So you have beautiful separation of those two groups in the retrospective study, but when you mapped it prospectively, absolutely no difference at all. So in IBD, I think personalised care remains a key aim. There are increasing numbers of drug, which gastroenterologists are getting used to, but there is a wide variety of clinical phenotypes. We know that we can predict severe disease using clinical factors, and that does guide our choice of therapy. There are those predictor tools which are available to help assess risk and the possible impact of treatments. But the only trial so far really to assess prospectively the efficacy of a biomarker that had previously been identified in a retrospective study have been negative. But it did actually have one really important outcome, which was it confirmed the really considerable superiority of top-down treatment for early Crohn's disease and the importance of getting in there early with anti-inflammatory treatment at a point where inflammation is the key problem in Crohn's disease and before bowel damage becomes the major issue. Thanks very much.
Thank you very much, Tim, for this very nice presentation. And I think it's now good to have some discussion on these topics. I would like to start first with Herve. And actually, Herve, you were suggesting that there are IL-23, IL-17 dominated pathogenic models, and that would not be so dominant in some of the patients with psoriasis. But if that's the case, do you think there are biomarkers that you foresee that will help us in daily clinical practice identifying or stratifying these patients?
That's a great question, Sofia. Yes, we believe so. Of course, I mean, this population refractory to the IL-23, IL-17 blockers, but also TNF-alpha blockers, was deeply investigated by several investigators, including us. And the type 1 interferon pathway that really emerged as really the most upregulated in the skin of some of these patients, we believe is witnessing the primary mechanism that is operating in these patients, which is more type 1 interferon deregulation associated than IL-23, IL-17. And what rang the bell in our minds is that some of these patients had psoriatic arthritis, and they received at some points upadacitinib as a JAK1 inhibitor, which worked very well, not only for the joint, but also on the skin, which fits very well with this type 1 interferon-driven pathway. We are not saying that this applies to all patients, of course, but at least in a subset of patients who are more refractory to the, let's say, canonical drugs, if you wish, like TNF-alpha blockers or now more and more IL-23 or IL-17 blockers. We believe that type 1 interferon is a serious candidate as a pathway to be investigated. We are working on identifying the genetic determinant of those. So the combination of transcriptomics with genotyping, we believe, is one of the multiple ways to have the right therapeutic strategy, more than precise treatment for a given subpopulation of patients. And brick by brick, population by population, we believe that this is something reasonably ambitious, but that would help to characterize the patients in the close and the more distant future.
Yes, thank you. That is clear. And one last question for you. Is this something you would foresee being used in daily clinical practice or more at the research level?
Well, I think the challenge, that's a great question. As you know, we have easy access to the skin, right? So skin biopsy and the molecular analysis of those through the transcriptomics is one way, which seems easy. It's not, but that might be simplified in the next years. So far, the transcriptome only based strategy doesn't help to rebuild the full hierarchy, the complete hierarchy of the inflammatory cascade in a given patient or a given population of patients. So you have to have other access to other omics and of course, genomics is one of those. So you have functional genomics, the transcriptome, that's already something. But probably the combination of transcriptomics with genotyping among other markers, also epigenetics, will help first to reclassify, then identify the clinical and eventually histopathological determinants, and then come back to a new subclassification, which is more based on the molecular patterns that only the clinical determinants. The clinical determinants, they matter. I mean, the type 1 interferon driven cases are very spectacular. Some of these patients, they have, instead of psoriatic arthritis, they have Jacques hand. So they have rheumatism, which is closer to the connective tissue disease than through PSA. So, but you can, yes, we foresee a sort of reclassification of the clinical determinant, but after a very key step, which is really the multi-omics approach.
Thank you very much. And now moving to you, Tim, and thinking about the trial you have shown as the profile trial. A very basic question. Is it about the biomarker or is it about the top-down versus step-up difference in terms of treatment? What leads to different outcomes?
I think that it was an interesting trial. It was designed very well, in fact, because it ended up with a very important clinical message, which was you need to treat early in order to get on top of the inflammation in Crohn's disease. And I think there have been a number of trials that suggest that, but it really sort of settles. I think it settled the argument. The biomarker was, however, completely it was not a useful tool in splitting who would respond and who wouldn't. So I think it's a salutary lesson for us that actually it's not good enough to do retrospective studies and analyses and sort of you don't know what your confounders are. And if you have small studies that are that appear to show a difference, you've got to then go on and do the prospective study. And I think ideally, in a way, if you design as cleverly as this study was done, in a way that will allow you both to define an important clinical outcome, irrespective of whether the biomarker is positive or negative.
Yes, thank you very much. I think I was asking the question in a provocative way because that was indeed my take home from the presentation of that study indeed. And then I'm always, as a methodologist, I always like to hear these comments emphasizing the importance of running the right studies, prospective studies, before we take decisions on associations that might be there, but actually are spurious or are due to other confounders. Totally right, and I totally agree with you. And if I could ask you a last question about which are then the key lessons learned from this profile trial for the future of biomarkers in IBD?
I think it's unfortunately, I think the key lesson is that we are going to have to invest time, effort, and resource in doing these trials prospectively. And of course, the problem is everybody wants the answer, and at the moment, you know, we have panels of immunological markers which you can use to help predict what's going to happen, but none of them have really been tested in this sort of way of actually making decisions in real time. And I think that's the bit that we will have to do more rigorously than we have been doing previously.
Thank you very much. I'm happy to hear you saying similar things to what I said, but in a different way, which is very nice, which is we see biomarkers, but the challenge will be seeing them used in the setting for which we want to use them in daily clinical practice. That's a much more demanding use, and that makes it much more challenging to find a promising biomarker that makes it to daily clinical practice. Okay. I think we would need to take in the time. We will need to wrap this webinar. Time went very quickly. Were very nice presentations by both of you. Thank you very much for your contribution to this webinar. And I would like to thank our audience for listening to us. And please be aware that the live streamed version of this webinar will be available to be seen on our YouTube channel of the Immune-Mediated Inflammatory Disease Forum soon. The content will also be available on the IMID Forum website. Please give us your feedback, because it's only with your feedback that we can improve these type of webinars, that we can know which are the topics you are most interested in. So take 2 minutes of your time to please give feedback to us. And I would not like to close before reminding you to keep an eye on the IMID Forum website on future webinars. The next webinar in the series will be entitled PSA and PSO. Is all inflammation the same, on the 11th of November. Feel free to register. Thank you very much for your attention, and thank you to my colleagues for your participation. Goodbye.
Thank you.
Thank you.